sutured up. On the other side, we used bone morphogenic protein 2 with Dr. Boyne's material, and Dr. Boyne was working with us on that until he died. Unfortunately, he died right in the middle of one of our most important projects. But at any rate, that case, that dog, both sides completely dehisced. In fact, there's one side the implant wasn't even there. So totally infection on both sides. This is the other dog. We did oxygen, just pure oxygen on one side. We took the big block out, threw it away, filled the cage with oxygen, put it in, screwed it in. The other side, we did fluoridated HA. And of all the 4 different jaws, the fluoridated HA here is the only one that didn't dehisce and get infected. The side with pure oxygen partially dehisced, so the bone underneath there got infected and of course didn't take. But both sides in the part where the augmentation took looked the same. This is the titanium. In fact, this section here represents this right here. On this, but you notice on these little parts of the cage, or several millimeters away from the osteotomy, we were getting bone that would integrate to the mesh several millimeters away from the original osteotomy, which for the implant brace concept is what we're looking for, because we want to bridge gaps of missing bone with a cage and have bone growth. Well, this is the first one that we saw that we could literally get the cortical bone to grow back and grow and integrate to the cage. And then, Doug, this part here that doesn't look, this is your medullary bone underneath, okay? So this is the cortical bone, and this is what you would expect. See, this cage was made to fit right where the cortical bone used to be. And so that's where we want the bone to grow. And lo and behold, it did, with just fluorapatite, or what we call fluoridated nanocrystals of hydroxyapatite. In other words, the surface crystal is fluorapatite, inside crystal is hydroxyapatite. And what that did, it allowed no infection to get into this area so that this area could integrate to the cage, and it integrated to the cage itself. Integration, see how that bone, this is all new bone right here, is intimate contact with the HA coating. That's integration, osseous integration.
If it wasn't, what would it look like then?
It would just a gap. It'd be a gap.
It doesn't go over the titanium.
It grows right on and over the titanium and totally embeds the titanium. You can't, I mean, it's almost a mechanical, I'm not sure if it's an ionic bond or whatever bond, but it actually attaches to the HA. And it does the same thing to titanium as well. You know, it'll do the same thing. We did we extracted the teeth. The Japanese did all this, and then 2-3 months later did CAT scans, and then they sent the CAT scan generated model to me. Then I took impressions of that, and then I took a burr and just took out what I thought was the cortical bone, like that, and then we waxed onto that a cage with screw holes in it, then cast it in titanium. So then I made a transfer template to transfer the exact osteotomy extent, so we could put that in the dog mouth and then transfer and cut the osteotomy out precisely. Then we filled the cage, dropped the cage in, and screwed it in.
This is some of the histology we got from these dog studies. In the center you can see the crystal, or the dark areas of crystal of HA, and you can see concentric rings around the HA of very immature bone. And this HA does produce very rapid bone formation around this HA material. Even though this is the HA side and a non-fluoridated, we see bone formation around the little cage struts in osseous integration. So the fluoridated side did the same thing, but it's interesting to note that several millimeters away from the original osteotomy, we get bone formation around the little cage struts. And this is a fluoridated side, and this is at very high magnification. And if you look at it very closely, you can see the little fluoridated HA crystals. And the same phenomenon we see here is immature bone that grows around these crystalline structures. And also here's the titanium with the HA, and we find this immature bone that's attached to the HA around the little struts. But several millimeters away from the original osteotomy, we have bone formation that is osseous-integrated around the cage, and it's indicated that we can grow bone in a cortical area far away from the original bone. This is the first experiment to show the implant brace concept and its ability to replace a cortical bone plate in situations like non-union fractures or areas where the bone is missing. We can build a bone cage out of titanium and HA coat it and fill it with fluoridated HA, and then expect that we're going to get bone reformation in the area of the cortical plate. This has great implications for orthopedic medicine.
One of the first cases I did with fluoridated HA, and this case here, this tooth here, which is, I'm not sure which is a central incisor, we put this implant in. Within a short time I had a periaqueal lesion, and actually this was draining up alongside the implant, and it turned out that the tooth nearby next door was completely necrotic. So we did a root canal, and I did a periapical and sealed it here and grafted this whole thing with the fluoridated HA. You can see where this thing drained, and all this, see the white on the implant? That's what infection does to these implants. It puts a white film on it. If you don't get that off, you're not going to get reintegration. So what we do is we go in and we citric acid and get that implant till it's shiny again. Then I go in with what now we know is like 4.6% sodium fluoride solution, and we know that fluoride does get into the titanium through, I don't know how it does it because fluoride is such a tiny ion that it does absorb some of it. So, and plus whatever fluoride it gets near the apatite and bone will be transformed into fluorapatite. So we just kind of wash it with the fluoride solution, and then we graft with fluorapatite, and this is what this looks like after you get done. And this is actually a picture 2 years later here, and this survived. You know, you take an x-ray of it now, you'd never know that it had bone loss. There's a Korean doctor that's a very skilled surgeon. He'll be here tomorrow. And I was in his office helping him with a custom implant because I've been training him on that, and he's so upset. There's this doctor that had been on the internet with me. We have an oral surgeon down in San Diego that showed me this case and said, I sent this case over to this oral surgeon to see what this was. Because he showed me the pre-CAT scans. There was a tiny little lesion up in the bone, but he didn't think anything of it, you know. And so then a few months after he gets the implant in, that little lesion now is the size of a dime, flat, you know, but diameter of a dime. And this oral surgeon wanted to take it out, regraft it. Of course, it's attached to a bridge, so by the time you get done with all the surgery, we wanted to charge Dr. Kim $7,000. We did an incision buccally because I thought a lesion like that had to come through the buccal. So I flapped it, and it didn't. It made a good slug of bone here. But palatally, there's the lesion right there, pulled away from the implant. You could see the implant and the bone. It was about 50% of the bone was gone from around the implant. And so I dissected off this piece, and we sent it in for histology. It was a cyst. It wasn't an infection, it was a cyst, a dentigerous cyst. So then there's the implant, and we cleaned this all out, and they're going through the etching procedure now with citric acid. And there's the citric acid, and just little cotton pellets. You go up and just clean until the implant, if it's HA coated, it's white, or it just becomes a pristine clean. You can see it. With the oxygen to turn it into fluorapatite. And actually, on this case, I actually took blood, and we made some PRP, which is platelet-rich plasma. And we spin down the blood and grab the platelets, and we mix that with the graft. And here's how we do the PRP, and the PRP is right there. And then we mix that with the graft and put a little thrombin, and it just clumps up the graft. So this is pure fluorapatite with PRP, and with a little bit of thrombin, it makes it into putty. And then we grafted that whole area,